Hey, good afternoon. Welcome to Facebook Live. This is Dr. Bill Bird, Chief Medical Officer at CGH Medical Center. Thanks for joining me. And today I'm really looking forward to a conversation I'm going to be having with my guest, Dr. Peter Toth, who is, he's an expert on lipids, cholesterol, triglycerides. So I'm going to be asking him some questions in the very near future. But before I do that, as usual, I want to give you all a brief COVID update. So some latest things that I just want to comment on. Saw today that Johnson & Johnson, the CDC came out that Johnson & Johnson, of the 8.7 million doses that have been given here in the country, 28 patients have had this clotting issue with that vaccine. So just to give some perspective on that, that's not good for any one of those 28 people, 3 of whom died. But to give some perspective on that, if you run those numbers, that's 1 in 310,714 people are having that reaction. And 1 in 2.9 million people are dying from that shot. You compare that to the risk and the odds of dying from that number of people, first of all, getting and then dying from COVID, being in a car accident and dying, being in a bicycle accident and dying. I think the odds are higher on whichever direction we should be pointing. The odds are definitely worse to be in those other things than to get a J&J shot. So just some perspective on that. And I think it's likely that a lot of folks will probably, that kind of information will drive more folks to get other shot options, as long as they don't mind getting more than one shot. So speaking of shot options, here's where we're at with that here at CGH. First of all, we are now doing in our main clinic we're going to try for a couple weeks to do a daily shot clinic. So anyone who just wants to walk in and wants a shot, we'll give it to them when they're here at the clinic at CGH. That's going to be a Johnson & Johnson shot. That's the plan for right now. So that's available to the public right now as we speak. Second thing, in terms of shot opportunities, this Wednesday from, I think it's 3 to 7, you can sign up for a Pfizer vaccine program, and we're going to do 12 years of age and up. So that's kind of nice, because of this 12 to 15-year-old group now that we can give shots to, we're hoping that'll be really helpful. So Matt's going to put up our data in terms of where we're at in the Whiteside County area. There's where we're at, and that's really encouraging, because you look at our positivity rate, which is actually lower than the state average, which for a long time we ran significantly higher than the state number of positivity. So looking good in terms of those numbers, and you see kind of on the graph on your right, you can kind of see how we've trended down after our surge that kind of hit us this last month or two. The other thing I just wanted to show you as far as that goes, Matt's going to show another graph, kind of our homemade vaccine versus, Matt will have it up here in a sec. There we go. So, and as we've talked about, basically natural immunity means you've had a COVID infection or vaccination. Those are the folks that make there be more opportunity for that virus to spread. And then if you look at the arrow, the variance and behavior are the things that make it more likely to spread. And it sure is trending. That arrow, we should have shifted the arrow towards natural immunity and vaccination, because it sure looks like we're trending towards those things really piling up. And the more vaccines that we can give folks, the more likely that arrow shifts farther and farther in the direction of people being safe when they move around with this infection going on. So I'm really encouraged by that, and also some other encouraging numbers. Let's see here. Yeah. We're going to do some things here at the hospital here in the near future too with that. I think we're going to, for the patients who are having surgeries here and other procedures at the hospital, in the pretty near future, if you've been fully vaccinated, we won't have to do a COVID test for you before you come in, and some stuff like that. That these improved numbers, as well as what we're seeing with how effective the vaccines are allowing us to do that. And make no mistake about it, I think the biggest reason that we're seeing this trend in this right direction is the cumulative effect of all the vaccines that are going out. So they're working. They're working really well. And I encourage folks to continue to get those vaccines, because the more that we can get in those arms, the better off we're going to be. Some other good news before I move to Dr. Toth. So today I saw something where we had the lowest deaths per day. That's 600 per day now than we've seen in 10 months. The lowest number of infections that we've had per day at 38,000 a day than we've seen since September. And the number of that have had one vaccine in our country now is 46.4%, and the number that have had both vaccines is 35.4%. All is encouraging stuff. Let's keep at it. I think where this is going to be, we're heading very much in the right direction. So I'm very encouraged by that. So that's COVID update for today. As always, as I'm having a conversation with Dr. Toth, just if you have other COVID questions or questions for Dr. Toth and I, please send those our way, and we will do our best to answer those. But without further ado, let's get Dr. Toth on. Hi, Dr. Toth.
Bill, how you doing?
I'm doing great. So Dr. Toth is hanging out in his office. Probably saw patients this morning, I'm guessing.
Absolutely.
Yeah. And Dr. Toth has an MD and a PhD. Is it biochemistry, Peter? Yeah. So really sharp guy. He writes books about lipids, and he travels around the world. Probably not as much this year as normal years, but he travels around the world and gives talks about lipids. So he's the real deal. He's going to be very helpful for us today in answering some of these questions about lipids. But before we get to the lipid question, or two or three or four or more, Peter, I have a couple of just personal questions. You ready?
Yeah.
All right. So just in terms of medicine, what made you decide you wanted to go in the direction of becoming a physician? And then what led you towards the path of family practice?
Well, when I was 12, my mother needed heart surgery. And she had heart surgery at the Leahy Clinic in Boston. And I remember going in to see her in the ICU. And remember, this is only about 15 years into heart surgery.
Sure.
So there were a lot of electrical wires and IVs, and it was very different back then than it is now. I remember being really stunned at this site, and the ICU nurse saw that I was a little puzzled and wasn't sure what to do. So she came over and talked to me, and she said a lot of very wise things to me. And in that moment, I said, this is really interesting. And I developed this real intellectual passion for the cardiovascular system. And my interest in science and math was very strong. So it seemed like a natural fit. But that's where it started. And then as I learned more and more about it, even in junior high school, I would go to the local hospital. If there was an autopsy, they would let me come in.
Oh, wow.
When I was 17, I assisted Denton Cooley in 300 open heart operations and at the Texas Heart Institute in Houston.
They probably wouldn't be doing that these days, would they, Peter?
Well, probably not.
But good for you.
But yeah, and then every summer from then on, I was somewhere. I was at the Texas Heart Institute. I was at Baylor in Houston. I was at the Rockefeller University in New York. So, but as I moved through college, there was a dual interest, not only in medicine, but also in science and doing research. And so ultimately, instead of just going to medical school from college, I decided it would be in my best interest to get a PhD first. Because once you were in medical school, the push would be to just go ahead and go straight through your clinicals and practice medicine. but the PhD was wonderful for me. Those were absolutely wondrous days of inquiry. I published a lot of papers, did a lot of research on heart mitochondrial bioenergetics, and I took twice the course load that I needed to graduate. But it was also a time of extraordinary exploration, quantum mechanics, kinetics, nonlinear, non-equilibrium thermodynamics, advanced physical chemistry. It pulled you out of the box and made you think in whole other ways. And in biochemistry, we think in terms of pathways, but in terms of these other hard sciences, everything was very quantitative and mathematical. So it gave me that dual discipline of being very precision in terms of my thinking when it came to mathematical issues, but then also piecing together pathways and understanding the biochemical basis of disease. And that was really quite a strong combination for me.
Yeah. Yeah. Family practice, though, where'd that come from?
Yeah, so that's a good question. And so actually, initially, I was, of course, very interested in becoming a cardiologist. But after my family practice rotation, cardiology seemed to be just a little too narrow, a little too focused. And it turned out that everything interested me, and family medicine seemed to be a better fit.
Yeah. And it has been. You've good career doing family medicine.
You can have a wonderful career in family medicine. You don't have to be a specialist to make a difference in people's lives. That's true.
Yeah. I want to ask you one other personal question before we get to lipids. So for our viewers, to Dr. Toth's left, behind his left ear is a photograph, I think I see there. And I know that Dr. Toth, when you go through, if you've been to his office, he has numerous photographs that he's taken at different places throughout the world. So he's really good at and really interested in photography. So what got you interested in photography, Peter? And do you have any favorite photographs that you've done?
Oh, sure. So when you think about photography, you're really thinking about trying to capture that image that just captures the extraordinary beauty of a place, a moment. And so if I go someplace, I do a lot of research ahead of time. If I know I'm going to do photography there, I try to learn as much about it as I can, what the lighting is like at any given time of day, what it is you can expect to see there, what are the pitfalls, is there danger in hiking there or in trying to seek a place out because it's so remote. So these are all things you have to explore ahead of time. But I think ultimately it's trying to capture that perfection of nature in the best possible way. And that takes preparation, it takes experience, it takes experimenting with your camera and being ready for anything because anything can happen. So I love that aspect of it. It can be very challenging, but it's also very rewarding when that image comes up and it's beyond what you expected.
Yeah. Pre-pandemic, I know there was we down our hallways here at the hospital will do artwork, and I know there was at least one of those where we had a lot of your photographs that just hopefully we can do that again sometime because they were really cool to look at.
Well, something that I think really impacted me, I have a very dear friend who's a lot older than me, and he's a very prestigious physician. He's also been all over the world. And uh, he noted that he found photographs on my website, and he asked me how it was that I was able to photograph so many places. And I explained to him that, like him, I had the blessing of being invited all over the world to either teach or present research. And I always made a point of making sure that before I left the place, if there was something beautiful to photograph, that I actually did that.
Mm.
And he broke down because he said he could have done that too, but he mostly spent when he had downtime, he spent most of his time in the hotel working.
Ah,
Now we all have to do some of that.
yeah, right.
But he said that he really missed extraordinary opportunities to see things that he should have taken the time to see. And in that moment, I decided that was not going to be me.
Yeah, yeah, yeah. Good. Okay, well, we could talk photography and those type of things. There's something about the spirit of the art gallery will feature. Okay, next week. Good. So we could talk about some of these other things for a while, but we probably better get into some lipids. Are you ready for some lipid questions?
Of course.
Okay. What's the latest role that diet plays on a person's lipids, Peter?
Yeah, so that's a great question, and it's been reevaluated by the National Institutes of Health actually in the last couple of years. And when it comes to triglycerides, which are blood fats, dietary intervention can be very effective because obviously, if you're consuming a lot of fat, especially saturated fat, and not consuming enough mono or polyunsaturated fat, this has very deleterious effects on your lipid profile. If you control the types of fats that you consume, this can reduce your serum triglyceride levels. It can, to some degree, to a very limited degree, reduce your LDL, the bad cholesterol levels. But in general, diet helps people who are insulin resistant or diabetic or have naturally high triglycerides the most.
Okay.
When it comes to controlling your bad cholesterol, the LDL cholesterol,
Yeah.
in fact, the latest guideline states basically dietary intervention is extremely limited.
Hmm.
And given the challenges of instituting significant dietary change, most people fail at it. Now, what do I mean by that? Well, sure, you can look at the work of Dean Ornish,
Right.
who is a cardiologist, and he actually has espoused the vegan diet. Now, when you talk vegan diet to people in the Midwest, you're not going to get a very positive response
You're
from
going to get a
them.
lot of traction, are you?
Yeah, because when you say you're going to live on lentils, uh, lettuce, and some legumes, people don't get excited by that. And they may say, okay, we'll try it for a few days. But in terms of a lifelong change in dietary consumption, it's not going to work. So, yeah, there are some select patients who can get their LDL down when they're high risk to say less than 100. But if you look long term, only 0.7% of high risk patients over the course of 1 year were ever able to get their LDL below 100. And for those high risk patients now, they actually have to get it to less than 70. And almost no one can do that on diet alone. So diet is limited. It's important because it can impact triglycerides. But for the so-called bad cholesterol, the LDL,
Yeah.
it doesn't do a lot.
Okay. How about exercise? What does that do, if anything, in terms of a person's lipids?
Yeah, so exercise is recommended on a daily basis, 30 to 45 minutes. And the nice thing is that if you're engaging in aerobic exercise, you can split that into two 15 or two 20-minute episodes, and it will contribute in the same way to your overall health. It's also recommended now that for people older than 45, they balance time between aerobic cardiovascular fitness and resistance training, because we know that maintaining muscle mass in both men and women is extremely important. You maintain muscle mass, you have a wonderful sink for glucose, you help reduce risk of developing insulin resistance, diabetes, and it also helps to reduce changes in bone that give rise to osteopenia, osteoporosis, because it helps to maintain good bone alignment and helps to maintain bone health. So the hip bones connect to the ankle bones connect to the knee bone, etc.
Right.
Everything relates to everything else, and exercise is important for everybody. But in terms of lipids, again, it's the people who are insulin resistant, diabetic, have high triglycerides. They derive the greatest benefit in terms of relieving the high triglycerides. And very particularly, it can cause some shifts in LDL in terms of the size of the LDL, which is believed to be beneficial. But make this simple. Exercise is good for everybody, no matter what their health status.
Sure. So you already alluded to some numbers, but just for those listening, what's the latest in terms of someone who would be considered like a normal risk person versus someone who's higher risk? And are there target cholesterol and triglyceride numbers these days?
Yeah, actually, for everybody, the triglycerides should be less than 150.
Okay.
If you're high risk, meaning you have established heart disease, let's say you've had a heart attack, you've had a stroke, or you've been stented, or you've had a bypass surgery, your LDL at minimum needs to be less than 70. Now, the lower, the better when it comes to the LDL. Why do I say that? Because we actually need to view LDL as a vascular toxin. I wrote a long editorial for the American Journal of Preventive Cardiology this month. And in that article, I go through point by point how LDL, which is a natural byproduct of lipid and lipoprotein metabolism in your body, actually functions as a vascular toxin. It's poison. So consistent with the principles of toxicology, if you know that you have lead or mercury in your water, you do everything possible to get rid of it. If there's a poison in your well, you know you're in big trouble. You somehow either have to purify it or you have to dig a new well. So LDL is the byproduct of lipoprotein metabolism. There really isn't anything you do with it. And we know based on any number of studies, the higher your LDL, the higher your risk for heart disease. But the lower your LDL, the lower your risk for heart disease. So now in the European guidelines, they actually reduced LDL targets to less than 40 in the highest risk patients who have had multiple cardiovascular events within 2 years. And why is that? Because it is now believed that a truly physiological LDL is around 40, not 100, not 130, not 160, it's around 40. But the problem is, on an evolutionary timescale, our bodies have not kept up with the changes in mechanization, lifestyle, etc., that would accommodate this. So this is why you have a worldwide epidemic in heart disease.
That is fascinating. So I'm going to throw another thing that I've been reading a little bit about lately. Is there, from your clinical perspective, an age where you would not be as aggressive about treating someone's cholesterol?
Yeah, that's a great question. And let me illustrate that with the results of 2 recent studies that were both published in the Journal of the American College of Cardiology. Half of all Medicare patients are not given a statin after they have a heart attack. Now, that is insane. Now, certainly some patients refuse statin therapy. Some patients will say, well, I tried it in the past, I didn't tolerate it, I'm not going to take it this time. But to say that 50% say that is a stretch. And it's certainly a stretch that I don't believe. So why aren't half of the patients who sustain a heart attack getting a statin when we know that statins reduce risk of dying by about a third over 5 years? They reduce the need for stenting. They reduce the need for being split open like a watermelon for a bypass surgery. They reduce risk of stroke, peripheral arterial disease, etc. These are life-saving drugs, and yet patients decline them. And some physicians feel that if a patient is 75 or 80, Well, don't bother giving it. Well, I'm afraid that's very poor medicine, because if someone is still functional, if their brain is good and their heart is still in pretty good shape, even after a heart attack, of course that person wants to live the best possible life they can. And to be able to say that this medication will reduce your risk of death, disability, and reduce the overall cost of your health care, that's a mouthful. And I think everybody should be given a chance to live the best possible life they can after having a heart attack or requiring revascularization. So to withhold a statin, to me, is crazy. Now, if someone's got advanced dementia, they have stage 4 heart failure, and they're lying in bed and can't get out of bed without getting short of breath, well, then it's time to talk to the patient and the family and make a decision about whether or not you want to continue or discontinue certain medications. But when it comes to someone who still wants a fighting chance and they want to live the best possible life they can, you never withhold a statin from someone who has sustained an event, ever.
Yeah. Okay.
And actually, Bill, let me highlight that a little more. We now have data out of Iceland, Israel, as well as the ProCam study in Germany, which now show that unequivocally, statins, even in patients up to 95 years of age, are beneficial. 95.
Okay. That's getting up there. Yeah. Okay.
Well, more and more people are living that long,
Yeah.
and it's something you have to consider.
Sure. So we've been talking about statins, and from a simplified standpoint, I would call statins the kind of the vacuum cleaner, the LDL vacuum cleaner, the toxin remover.
Yep.
That's what the medicine does. So as far as statins go, Peter, how do you decide what statin you want particular patients to be on? Do you have a go-to? Do you mix and match? Tell us a little more about that.
Yeah, so a lot depends on what their baseline LDL is and where they need to go based on their risk stratification. So if someone's very high risk, there's generally only two statins I'll consider. That would be rosuvastatin and atorvastatin. If they're lower risk, but they want to do everything they can to reduce their long-term, their lifetime risk for developing heart disease, let's say they're 35 or 45, and they say, hey, doc, I want you to give me the best possible likelihood for me not developing heart disease because my father had heart disease by the time he was 50.
Sure.
My mother had a bypass when she was 60. Then you generally can get away with a lower potency statin if their LDL is not very elevated. But bottom line is, I do like to get LDL down aggressively, because if you're going to use a statin, you may as well get as much bang for the buck as you can.
Okay. And so for the folks listening, rosuvastatin is Crestor and atorvastatin is Lipitor, for those of you who are used to brand names. Okay. And you also alluded to that some patients are resistant to being on statins because of concerns about side effects. Can you speak to that? Can you speak to the typical side effects that patients experience and how you help to mitigate those side effects?
Yeah, so this gets to be very complicated. I think far and away the most important potential side effect of statin therapy is going to be the muscle aching. In very rare cases, it can be accompanied by muscle weakness, where patients truly have difficulty with mobility, executing activities of daily living. Those cases are about 1 in 1.5 million.
Wow.
But in terms of muscle aching, the clinical trials suggest that rate is somewhere between 1 and 3%. Unfortunately, in the real world, that rate is somewhere around 1 in 5. Now, when I think back maybe 20 years, it was very rare for me to encounter a patient who complained about muscle aching on a statin. Now, it's extremely common. So, what's changed? Well, we haven't changed biologically, have we? Human skeletal muscle is still the same as it was 20 years ago. But what we do know is, without any doubt, that when there's any negative press about statins, there's a large number of people who discontinue them.
Mm.
The Copenhagen Heart Study evaluated this issue, and it could be radio press, it could be print press, television. If there's anything negative, bam, people want to go off. And yet it's a huge mistake. Huge mistake.
It almost sounds like it has some similarities to our vaccine issue right now.
Yeah, of course. And when you Google statin, it's typically the negative stuff that comes up. Now, if I looked you in the eye and told you that this pill in 5 years can cut your risk of mortality by a third, it'll reduce your risk for needing stenting, bypass surgery, reduce your risk of heart attack, stroke, even reduce your risk of requiring lower extremity revascularization by big numbers, a reasonable person would say, yeah, give it to me. I mean, if you said that about cancer, they'd kick the door down for it. But you say the word statin, and all of a sudden, people go, oh, I don't know about that. My friend at the Red Apple Diner said it was bad things. Or my friend told me that you're trying to poison me. Or my friend told me that, well, you're not going to be able to think straight again. So there's a lot of what we call the nocebo effect involved in this, meaning that because you're going into the mission convinced that something bad is going to happen, in fact, something bad does happen. Namely, you blame everything that happens on a statin. So there's going to be a paper coming very soon in a very prestigious journal out of England. And and I'm mentioning this because a brief summary of the results were already presented in the New England Journal of Medicine. And what they showed was that when you take patients who claimed to be absolutely statin intolerant and then randomize them to a sugar pill or a real statin or to nothing, it turns out that when you follow these patients up over 1 year's period of time, when they had no clue what they were taking, there was no difference between the sugar pill and the statin pill in terms of tolerability.
That is really interesting. Okay.
And so that was already presented at the American Heart Association meeting and published. So I can mention that. And so the issue is people blame everything on the statin. They say my left shoulder hurts now. It doesn't work that way. If a statin is going to cause pain, it does so bilaterally. It's virtually never unilateral. Or they say, well, now my knee hurts. Well, when you do an x-ray, they've got, moderately severe arthritis. Well, that's not from the statin. That's arthritis. And so this is why we have to be very careful. Now, what else? This cognitive clouding issue. People say, well, I can't think straight. Or, ever since I took that statin, I can't find words. Well, that's been disproven. So the heart protection study was a study of 22,000 patients. They looked at the issue using 5 validated cognitive batteries. So they looked at 5 executive functions and evaluated patients over 5 years of therapy with simvastatin. There was no between group differences in terms of any impairment in cognitive function. The PROSPER trial actually looked at patients 75 to 82 years of age. That was a 4.5-year study. Same thing. And then most recently in the Ebbinghaus trial, they actually looked at people who got their LDL as low as less than 10 milligrams per deciliter. So this was aggressive therapy with statin plus evolocumab. And once again, when they used what they call the Cambridge cognitive battery, which looks at 5 executive functions, and they looked at before the initiation of therapy and after therapy was concluded, no between group differences. And probably the most remarkable thing about the Ebbinghaus study was that when they looked at patient questionnaires, so patient self-assessment, no between group differences in terms of self-perceived alterations in any form of cognitive activity.
Yeah.
So this really is a dead issue. It's been evaluated multiple times, and
Yeah.
lipid lowering per se, and statin therapy per se, and PCSK9 monoclonal antibody therapy per se do not cause cognitive clouding.
Wow. Okay. Good stuff. How about the concerns about liver enzymes? What that's one. It's maybe not people aren't think about,
Sure.
but it's obviously something that
That's absolutely important. Yes. Now, the risk of liver failure on a statin is about 1 in 1.1 million people, which is exactly the background rate in the general population not on a statin.
Okay.
So the risk of
Yeah.
liver failure is essentially zero. Now, when patients bump their enzymes, it's most commonly not because of the statin. It's number one, because they have underlying fatty liver. And actually, patients who have fatty liver, two of their liver enzymes, the so-called ALT and AST, they can undergo an oscillation because there can be changes in the intensity of inflammation within the liver that correlate with rises and reductions in those transaminase enzymes. That's not the statins doing. The problem is so many patients with dyslipidemia who need a statin also have concomitant fatty liver. And it is a big, we just finished a big position statement for the American Heart Association on fatty liver. And one of the most important points that we make in terms of therapy is to not stop the statin in patients with fatty liver, because actually there are studies that now show that those patients do better and have better liver preservation over the long run than if you were to, in a knee-jerk fashion, stop that statin. So that's number one. And if a patient does bump their enzymes, you really need to look for fatty liver. And then second, which is also very important, if someone bumps their enzymes on a statin, you have to think about drug interactions. And you know, some people are on lots of drugs,
Yeah.
and patients are very good about this. A lot of them ask, well, if I take this drug, is it okay to use in combination with my other medications? And so that's something that's always very important to check, because different statins have different metabolic pathways they go through in order to be metabolized and disposed of. And so making sure that they're not experiencing a potentially liver toxic drug interaction is also extremely important. Are there patients who spontaneously bump their liver enzymes taking a statin? Very rarely. Yes, it can happen. But if that occurs, you need to stop the statin and then ask the question, is it fatty liver? Is it a drug interaction? Or is there some baseline abnormality within the liver itself, other than fatty liver, that is rendering that patient's liver very sensitive to the statin?
Yeah. Good stuff. Well, Dr. Toth, I have way more questions than we have time, but I do appreciate the time that we've spent.
Let me just add one thing. We talked about COVID. So if there's something that needs to be emphasized about COVID, it is that the patients who are diabetic, patients who have established cardiovascular disease, patients with hypertension, patients who have bad cholesterol, all of them are more vulnerable to infection with COVID because they all increase expression of the receptor that COVID binds to, especially in blood vessel walls. And the problem here is that patients with heart disease are particularly vulnerable to having their arteries and heart infected with COVID because of this increased expression of that receptor that the virus binds to. And because patients with heart disease already have augmented inflammatory tone within their cardiovascular system, it is strongly believed that this also can increase risk of the most dreaded complication of COVID, which is the so-called cytokine storm syndrome, which has an extraordinarily high fatality rate because inflammation goes hog wild throughout the body, and this leads to multi-organ system failure.
Yeah.
If you are taking drugs for your high blood pressure, your diabetes, your heart disease, your cholesterol, make sure you keep taking them and take them as they were prescribed, because these drugs can reduce the intensity of inflammation, likely influence the capacity of the virus to infect your cardiovascular system. And it's been shown that adherent patients have lower vulnerability, not only to infection, but also to more severe courses and death. So that I think is important. And I'm also going to reinforce what Dr. Bird said: get vaccinated. Please, you're doing yourself, your family, the people around you, and society a huge service, because if you don't get vaccinated, I'm telling you, this virus is going nowhere. It's an extremely dangerous virus, one whose overall behavior we've never seen before. Get vaccinated, because if you don't, ultimately in the long run, you're going to get infected. And the problem is, once you're infected, it has a very unpredictable course. Protect yourself. It is crucial. Bill, thank you.
Yeah, thanks, Peter. Great having you on the show. And for everyone watching, please pass this on to folks so they can have a chance to listen to what Dr. Toth has to say today as well. Until next week, great having you join us, and we'll